Okay, so either a bad outcome happened or you had a situation where it could have happened. Both of those are indications to undergo root cause analysis.
Absolutely. So, how do I even identify the event? Do I just say, hey, Saul, something happened. We got to check in? Well, hopefully, the hospital or the clinic has a reporting system. And the basis of any good reporting system is you have to be able to report without feeling of retribution or getting in trouble. So, everyone has to trust the system. So, in our hospital, in our clinic, we use a system called iReport. But I'm curious, Saul, what do you guys use?
We actually have a committee that I actually sit on. It's called the Multidisciplinary Excellence Committee. And anyone in the hospital, regardless from clinician, non-clinician, parent even, can recommend cases for us to review. And it's basically this monthly committee. As its name implies, it's multidisciplinary. We have people from 15 different specialties that sit on it. It's totally confidential. Like most morbidity and mortality conferences, it's non-accusatory, it's non-retaliatory, and really has that tone of learning in mind to educate, identify, and correct, systematic mistakes so that we can not do the same thing in the future. And basically what happens is these cases get identified. One committee member reviews a case and then presents it to everyone else. After hearing that, looking at all the evidence, and there's forms to fill out, everyone votes to decide if the clinicians met the standard of care or if there's a quote learning opportunity. And then they talk about what type of issue led to those error. Was it a systems issue? Was it clinician judgment? Anything like that? And just for balance, the committee also brings up cases where care was provided that was exemplary and excellent, and gives props to those clinicians, because it can't all be negative feedback. Otherwise, it gets a little depressing.
No, that sounds like you're kind of doing mini RCAs within this committee already.
Yeah, no, definitely. And I feel like for, my big children's hospital and, like in your children's academic setting, this is something easy to do. But what should like a general pediatrician in a clinic, once they identify an issue like this, like, is it possible to do an RCA within a clinic?
Definitely, definitely. So let's go to step two. So step two, after event identification, step two is team formation. So ideally, and you can do this in a big hospital or you can do it in a small clinic, a multidisciplinary team is assembled to conduct the RCA.
And Liza, how is it decided who's sort of in charge of this team to put it all together?
We'll talk about the ideal team in quotation marks, and then maybe we could talk about a few substitutes if the perfect our ideal team is not able to be formed. So ideally, there should be a subject matter expert on the event or the close call process being evaluated. So somebody who maybe has some additional training in patient safety, has an interest in it, understands the RCA process, that would be an ideal team member, and that would be an ideal team member leader. Then you also want someone who was not involved in the event under review. That is too much emotion that is, wrapped up in something like that, that an individual, so somebody who is familiar with the clinic or the hospital but has not been directly involved in the case under review. Another leader who is well versed in the RCA process, that might be helpful. Some frontline staff working in the area, that would be helpful. And if possible, maybe a patient representative like you brought up, Saul, that patients and families should feel free also to be able to report events that they feel were unsafe or could potentially have led to patient safety issues.
All right. So it sounds like we got people, interestingly, people from various walks of life at the clinic, but not necessarily the people directly involved in the incident. I do think that helps keep it objective, because I think it would be very easy to turn very subjective and defensive if you felt like you were on trial. That would not be a good thing.
Absolutely. And the recommendation is initially about 4 to 6 team members. And just like you said, those that should not include those directly related to the event.
And does that mean that you don't get information from those clinicians, or do you, like my committee does, do you seek out feedback from those people?
You should still definitely seek out feedback. I mean, there's always so many sides to this story. So the people who are intimately involved with the event or the case under review should definitely be talked to. And hopefully, if you have a culture where people are trusting the system and trusting the reporting, it won't feel attacking, kind of, for lack of a better word.